Dr. Turner?
Thanks so much, Dr. Dusk. I should acknowledge right off the bat that the work that was done for this project was at UT Health San Antonio, and all of this is a Texas-focused study, even though I've moved westward. And I want to tip my hat to a wonderful team there. Let's see, did I share my screen? Yes, here, let me share my screen again because I'm not sure it's moving ahead. Yeah, so I don't have any disclosures other than I work part-time for the American College of Physicians. And I think we've heard this a lot, but I just want to hammer it home a little bit more. As an internist, end-stage liver disease and liver cancer, the one that especially is due to chronic cirrhosis is hepatocellular carcinoma. They really are pretty scary diseases and quite deadly, even though we have more tools. And, you know, the estimates vary a lot depending on which population you're counting, but there are certainly millions in the US who have chronic HCV, and anywhere from 40 to 50% of them don't even know it. It's a really insidious, sneaky disease until it really gets to be more advanced. Unfortunately, most of the people who have this are low income, and their access to these marvelous drugs can be quite threatened without an infrastructure to deal with that. So this project, as I mentioned, was in Texas, and you can see in blue over here, that's San Antonio in the middle. We also partnered with folks in Dallas at UT Southwestern later on in this project, but it's called Stop HCV, hepatocellular carcinoma and HCV. It was really to implement the full spectrum of screening to treatment for chronic HCV, and at the time it was really baby boomers were the focus of the mandate for screening, although now fortunately it's a much broader mandate to screen everybody who's an adult. And it was in 23 primary care practices in 6 healthcare systems in South Texas. Now, these were mostly federally qualified health centers. All of these practices served low-income patients, primarily Medicaid and uninsured. And it was funded by, I've got to tip my hat to CDC and other federal agencies, as well as state agencies that provided the support for this project. Let me just mention one other thing. These practices are in orange here, shows you where their locations are in South Texas. Now, what about South Texas? It is predominantly Latino, Hispanic, Mexican American mostly, 80% in that region, as opposed to well less than 50% in the rest of the state. The other thing is that it is an area where incomes are very low, with a lot of patients, you can see here, living below the federal poverty level for a household, which is in the 40,000 range. So these baby boomers, although we aren't focusing on them only for screening now because we're getting a spread of HCV in all age groups, they still represent the vast majority of chronic HCV infections in the US. And a while ago, the estimate was somewhere less than 500,000 Texans had chronic HCV. And look at the map here. You can see where they're concentrated in the black along the southern part of the state. And it kind of parallels when you look at the incidence of liver cancer in Texas. It is, first of all, higher than nearly every other state at 9.3 per 100,000, with 22,000 new cases annually. But in South Texas, it's vastly higher. And you can see here in the red again that the highest incidence of liver cancer is down there in the south of the state. So we used an implementation framework with REAIM to structure this implementation project. It's really looking at how well we could put into place the pieces of the puzzle to screen and then eventually cure HCV. And so it's reach, adoption, implementation, effectiveness, and I'll talk a little bit about maintenance, although I think that's where the rubber meets the road eventually. We've talked a lot about NIMHD's framework, but this is, I think the CBPR, the community-based participatory research goals, are really a wonderful touchstone for us because we wanted to enhance community capacity with this project for projects that we think we hope, and we wind up collaborating with them to make sure it's something that's relevant to them, that could be sustainable. And we especially wanted to translate research findings into these communities that really had not benefited from them. So start out by reaching out to the community. I think all of us today have spoken about that. We went to little towns all over South Texas to have focus groups and surveys with community members and patients. We also spoke with the practices throughout the region. And it's not just the administrators. We really wanted to get the whole team involved in thinking about the priorities and barriers to implementing screening. And it's not just educational initiatives, but also approaches to make all of this less burdensome. And I think that's one of the catch-22s of screening and implementation, is that it can wind up just burdening the practice. And here's a picture of a meeting. And these outreach community events were super important. And it was important that we had materials that were in Spanish and English, easy, attractive to look at, to help people understand this disease, because we've heard about the fact that the community really doesn't, a lot of them haven't heard about hepatitis C, doesn't understand why they should care about it. So we had community health workers. We've already heard about how important they are. And in this case, they were crucial to connecting. They were bilingual Hispanic community health workers who got out there and were very approachable. We had peers who were engaged, as well as our faculty. We got testimonials, people who were diagnosed sort of out of the blue, shocked by it, and then were treated to cure, about that whole journey, so that people could look and listen to that story and hopefully relate to it. The professional education involved a number of PowerPoint presentations and all aspects. I just want to point out down below that alcohol was a big cofactor in this population, in terms of once you've cured HCV, if you don't address that, the fire will continue to burn in the liver. So we really developed a series about not only diagnosing and treating HCV, but also managing some of the other risks. These were given at meals. We brought in nice meals. We gave them CME and CNE. We had to have some carrots to have people attend. And we developed a website. You can see it's here, which pulled together all of these resources and included the bilingual low literacy resources for the community. So these are the phases of the implementation project. And I think you've heard a lot about all the components that you need to implement to really achieve a cure. I'm going to highlight a few. You've heard about them before, about the EMR and opt-out, but I just want to mention a little bit how important they were in our practices, because they varied a lot across them. We did a little work on our own about mobile apps, and the care navigation was beyond important for this population. You can think of them as having huge problems with transportation, large distances to travel, usually have to rely on public transportation. These were a big deal to get people in to be seen. And we'll be talking more about how COVID affects this kind of delivery of care. And then we have a very interesting model for specialist consultation. And eventually on the side here, I just want to mention that the access was through free drugs that you can get through the drug companies if you meet an income criteria. But we didn't just pay attention to treating the HCV. We managed a lot of other comorbidities in this population. And so a cure is a sustained viral response at 12 weeks. But you're not off the hook. If you have cirrhosis, you need ongoing monitoring. And that actually worries me in some of these practices where the infrastructure isn't built very well. So we talked about the EMR. What I want to talk about is the problem if you don't have it. So in a number of these practices, they didn't have a flag. You couldn't put in a flag. Sometimes it just took a lot of money, which we didn't have. And sometimes it just couldn't be changed. And occasionally practices actually were still on paper. So you can imagine how cumbersome it is to have a patient come in and have someone on the team take a look in the chart to see if they needed to be screened and then order it and keep an eye out for the result. One of the workarounds is we collaborated with the big companies that performed lab tests for their population to get the lists of tested patients and results for each clinic, so they could at least have that reference. But it was incredibly cumbersome for some clinics. And then we also wanted to create a registry of patients with chronic HCV. We heard briefly about opt-out. I think that's super important. As an internist, I really don't have time to go through a long la-di-da about why somebody should be screened for hepatitis C. So we had posters we put up all over the practices. The CDC, I've got to tip my hat, had some wonderful ones that we used. And so we could just say, you're a baby boomer. Everybody has to be screened for hepatitis C. Have you had that yet? No, good. I'll put it in, that kind of thing. And then the rest of the explanation is there in the poster. That reflex testing, I think you heard about it briefly, but it means that when you're anti-HCV positive, they take the same blood sample and they do the RNA. Well, we'll show you some data that it's a big problem if you can't do that, because the patient has to come get contacted and come back in for a second blood sample. That's, I think, another big recommendation of an expert panel that's out there in the US trying to think about ways to accelerate this screening. So this mobile app we made was in Spanish and English, and it's built on qualitative studies that we did. Patients were diagnosed with chronic HCV because they were really confused. I mean, the stigma was shocking. They had said, well, my family says I'm not allowed to hug my grandchildren anymore, and I can't use the same silverware. I mean, it was really staggering. So we made sure that we put together an app that explained A, what it was, B, what it meant for your lifestyle, and C, the opportunity for a cure. These specialist teleconference hours, there are other models out there for supporting a PCP and with a specialist, but we decided it needed to be super brief. And so what we came up with is lunchtime case presentations that our PCPs could do from any of the practices. He was just going to set aside the hepatologist this time. And they discussed not only which regimen, but also other clinical issues that probably needed to be addressed along with the treatment. The sad news is, and I just have to say that we really didn't have much of an option if somebody had already developed liver cancer and they were uninsured. It was a very difficult situation. So here's an example of a case summary. It just shows you the diagnoses, their medications, substance use, all of the relevant labs, the ultrasound. I'm highlighting here that FIB4, which is a wonderful metric, I think, of how advanced the fibrosis is actually a low number here, but this patient actually had a very high number of the HCV quant. So that would have affected his or her treatment. The other thing is we really didn't care at the end about the genotype. So that saved us a lot of money because of the pan-genotypic drugs. So what about effectiveness? This is I think, a very helpful model to think about those pieces. And we published all of this in a paper in the Annals of Internal Medicine about 2.5 years ago. The quantitative measures had to do with screening, but then from there on in, it had to do with the care of the uninsured and whether they got counseled and finished their testing, and the care plan was developed, they got their free drug, they finished it, they got cured. You can imagine there are a lot of steps. Sorry. So this is, I have to orient you to this slide. These are the characteristics overall of everybody across all of those practices. And there were 27,000 people came in over the duration of the study, which varied somewhat across the different practices, but was no shorter than 9 months. So we had 48% of them were screened. This is from 0. We had a baseline of 0 at all these practices. Only screened people. It wasn't really screening. We tested people if they had elevated LFTs, but there was no screening that went on before. The demographics of the population, or these are baby boomers, more women than men, because women are the ones who come in to get primary care. Mostly almost 90% Latino, and 2/3 were uninsured. This is Texas, remember. What I want to show you are the kind of contrasting experience, because this kind of brings to light some of the models that we need to think about. In this best performing practice, 71% of the patients were screened. They had an EMR that could be modified, and it flagged who needed to be screened. The demographics very much, this is really wide in the border, so almost 100% Latino. And this, the worst performance clinic, only tested 20%. And so we started to wonder what was going on here. The demographics are pretty much the same until you come to the uninsured. And in fact, this is a clinic that mostly serves Medicaid. So I don't think that's a big clue. But look at the anti-HCV plus rate here. You can see overall it was 5%. In the clinic that tested almost everybody, it was only 2%. It was 19% in this clinic. And then as you go down, you can see the HCV RNA shows that, again, a much higher proportion of these patients had chronic HCV infection, a fairly low proportion of the best performance clinic. These guys were just really looking at patients and screening, I think, on the right, those who they thought were at risk for having had substance use or using needles. This is not the point of screening. And this is actually a sadly and realistically a care cascade that you see with all of these steps of care that are needed. And these are uninsured patients. Remember, they had no coverage for all of this without our grants. So we had 205 that were diagnosed with chronic HCV. Most of them completed staging. Most of these had the consultation done, although part of it was just the logistics of getting all the data together and scheduling. And then not all the patients were recommended to start treatment right away because of some of the other major issues that were going on, like ragingly uncontrolled diabetes, or severe problems with substance use, such that they really couldn't even bring them in. Then once we could get to the companies, get the drug, and have the person start it, we had a lot of success. So there are still so many steps in this cascade to try to deal with. So I just want to conclude with some of the challenges, as if I haven't already brought them out, which is these are incredibly busy practices with lots of competing priorities, and federally qualified health centers have as their metrics right now, I looked it up, diabetes control, hypertension control, and low birth weight. HCV is nowhere on the radar for them to try to meet any kind of metric. Sorry. And the other is that there isn't a financial incentive for HCV screening and care. I'm really bothered by the fact that NQF doesn't have one that would really make practices use it as a metric that they would want to meet. The EMR I already mentioned. If you don't have coverage for tests, even screening tests, the uninsured will say, well, how much does it cost me? And then I didn't talk a lot about the care managers, but they were really amazing people who kept with patients, made sure that they solved a lot of their logistical issues to try to get care, treatment, and adhere to the therapy. And as I mentioned, we could get free drug if you were uninsured. At the time of this study, it was worse to be on Medicaid than it was to be uninsured, because on Medicaid, you had all of these problems of, you had to have more advanced fibrosis, you had to have not drinking for 6 months. And they required it to be a specialist if you prescribed the drug. So we had co-signatures. All of this was removed. And I have to say, it may have been in part because we were really partnering with the state throughout these projects. And I think this is really an important advance. So I think most of these are logical, but I want to say that as an internist, if we could figure out how to make this supported, especially in practices that serve low income patients, without the infrastructure that was supported by the grant, it's very worrisome whether this could continue. And it really takes having the belief that the state or the feds need to invest in this population. Unfortunately, this is where chronic HCV resides in this country. So I just want to acknowledge the funders and an enormous team across South Texas of wonderful people who are in the front lines, as well as a team at UT Health San Antonio. The project that I left was taken over by Bertha Penny Flores, and we have this ongoing partnership with UT Southwestern, but it really does take a village. So thank you very much.